5 attendees and 5 panelists.
Yeah.
When shall we start, sir?
We'll start whenever you're ready.
Yes, sir. Yes. So, very good evening, everyone. So, this is the 7th session in IPSKC Telearogya team coordinated psychopathology series, and every week on Friday from 7:30 to 8:30 we are having the psychopathology series, mainly targeting our postgraduate students. So today we have chairperson as Dr. PSVN Sharma sir. He is chairing the second session. Last week also he has chaired this session, and our today's speaker is Dr. Gopal Das, and he will be speaking on the disorders of consciousness and experience of self. So even though it is a formality, I would like to introduce our chairperson again. Anyways, I have introduced sir last week already. Sir has completed MBBS in Maulana Azad Medical College, New Delhi.
It's okay, Narayan, we can skip that. Let's go to Gopal Das's CV.
Okay, sir. Okay. Thank you, sir. Harish, next slide. It's a privilege to have PSVN Sharma sir as the chairperson for second session. And we have our young and energetic speaker, Dr. Gopal Das, and he has completed MBBS from JSS Medical College, Mysuru, and completed his MD in Psychiatry from Bangalore Medical College and Research Institute, Bangalore in 2013, and worked in Basaveshwara Medical College Hospital, Chitradurga as Assistant Professor of Psychiatry from 2013 to 2018. Currently, sir is working at the same center as Associate Professor of Psychiatry since 2018 till date, and he does private practice at Pragna Mind Care, Chitradurga since 2014. And his areas of interest are affective disorders across the lifespan, personality disorders, obsessive compulsive disorder, and he has special interest in child and adolescent psychiatric disorders, especially ADHD. Other areas of interest are like medical education in particular, and AdCom competencies, training and research, and medical literature and translation and poetry. And he has been a fellow of Indian Psychiatric Society, fellow member of Indian Association of Private Psychiatry, life member of IMA from Chitradurga branch, member of Association of Health Professional Educators of India. I welcome you, sir.
Thank you, sir.
I request Chairperson Dr. PSVN Sharma sir to speak a few words on the topic.
Thank you, Dr. Narayan, and the organizers, and to IPSKC for giving me this opportunity of taking part in the series. I just noticed that the last speaker, Bhimsen, and the current speaker, Gopal Das, both have an artistic bent of mind. Bhimsen was interested in music and painting, and I noticed that Gopal Das is interested in literature and things like that, so poetry, and that's nice. As far as our postgraduates are concerned, I think many of you might or might not have heard of something known as the folds hierarchy. This is one way of conceptualizing psychopathology, that things to do with alteration in higher mental functions come at the top of the hierarchy. That means all other phenomena will be subsumed under it, go down to the hierarchy to the psychosis, and then other phenomena are subsumed under it, so on and so forth. So consciousness is somewhere at the top of the pyramid. There are many ways in conceptualizing consciousness. It's actually not just a psychiatric or a psychological area, but it's also an area of neurophysiology and, more importantly, philosophy. There have been many debates related to consciousness. People talk about it as a stream, people talk about it as a content, people talk about it as a composite of time, emotion, and event. Uh, Whatever it may be, it is extremely important for us in examining a patient and understanding what is the content of consciousness and what are the implications for us in terms of disturbances of consciousness and psychiatric disorders. So I am sure that Dr. Gopal Das will be dealing with these things, and of course you can raise questions in the chat box as you go along, and Dr. Gopal will answer you. Over to you, Dr. Gopal.
Thank you, sir, for the wonderful, insightful words. Even I learned one more thing from you, sir, right in the beginning. Thanks for that introduction. Shall I start sharing my screen?
Yes,
Yeah.
of course, of course.
Thank you. I have some issues. Okay. Okay. I hope it is visible and I'm audible too.
Yes, yes.
Yeah, it's fine. Go ahead.
Yeah. Good evening, everyone. And thank you for the introduction. I beforehand, I thank IPSKC and Telearabia to have organized this event. And I have watched previous episodes, and this is coming really very good. And I wish I was a PG at this time. We could have made use of this in a very good manner. So before much of a lapse of time, we'll start with it. Today's session will be disorders of consciousness and experience of self. Just a minute. Okay. As Sir told, this consciousness and self raises very few fundamental questions. That means, who am I? What am I? Where am I? How do I know I am me? What is not me? And how do I know what is me and what isn't? These are questions which are posed by mankind from millennia. And not just psychiatrists. It has been a burning issue of debate in psychiatry, neurology, all related fields, psychology, as well as philosophy and theology. There are various explanation in variety of angles, ultimately seeking the truth of what is consciousness, what is self, who am I, all those things. But rather than going into a lot of philosophical and theological ideologies, we'll just stick into the psychiatry and to the psychopathology. We'll try to answer. And what is there in this presentation? We are doing it in two sections. One is disorders of consciousness, and section 2 will be disorders of self, including a subsection on depersonalization. I hope we get a time to explain depersonalization. And more importantly, just a minute, sorry for that. Just a moment. Okay. In disorders of consciousness, I hope you're all seeing the screen. The consciousness and unconsciousness definitions. Are you able to see the screen?
Yes, it's
right.
visible. Yes, it's visible.
Okay. There was some snag in my laptop. Sorry for that. And quantitative and qualitative disorders of consciousness and other few states described as disturbances. And depersonalization in disorders of self, concept of self needs to be understood, and dimensions of experience of self, and then disorders of self explain over these this one, and a subsection of on depersonalization, definitions and components. What is not in this session is we don't discuss detail on neurobiology, on clinical presentations or method of examination, and there are few adjacent topics like disorders of cognitive functions, including attention, concentration, orientation, sleep disorders, and disorders of bodily awareness are slightly out of the scope in this. Now coming to disorders of consciousness, to think of consciousness, I'll just wrap up this slide a few fastly. We need to be someone who really exists and to be in state of awareness to experience both the worlds, outside and inside. And that state is what called as consciousness. This makes person capable of experiencing, and it is the readiness which enables a living organism. It again varies in alert state, drowsy, and deep sleep, which we are going to see in future slides, but yet enables a person to still experience, but in varied degrees. Pathological states affect the ability.
Gopal, sir,
Yeah.
sorry to interrupt,
Hello?
sir.
Sure.
There is a black strip coming on the slides. So Sriram is telling
Okay.
if you can mail the PPT to him, he can run it. Or else if you can correct it,
Okay.
then it's fine.
I'll just stop share just a minute. Okay.
In the meanwhile,
Visible now?
Yes,
yeah, it's
now it
visible.
is fine.
Okay.
Can you ask everybody to put off their mics because there is a sound of a child coming in between also.
Yes, sir. Sriram, sir.
Yes, sir.
Okay. Is it visible correctly right now?
Yes, sir.
Yes.
Okay. Shall I go on? Thank you.
Yes.
Right. We were talking about the variation of consciousness in various states, like, and lower the state of consciousness, the report will be poorer, and perhaps the actual experience, who knows. And it is the unconsciousness which make person not ready to do the same, like experiencing, but we could not get any, like no subjective reports could be obtained. It is just like what I felt, just like waiting for the light coming from a black hole and knowing what is inside. So we cannot know what is the subjective report of an unconscious person. So various experiments have been performed, functional and structural detailing of brain and mind, but only gives concrete data. Answers why, but not what and how much of experience is there. And coming back to some of the ancient Indian descriptions, Indian psychology or Ayurveda or yoga, they have described various states of consciousness. There are 4 states of normal consciousness called as avasthas. Jagruta, Sushupta, that is Jagruta means awake, Sushupta means sleep, and Swapna means dream. And there is one more 4th level of consciousness which is called Turiya, which is probably transcendental, which is not in the scope of this psychopathology. And there are also some abnormal states of consciousness described, especially in Ayurveda. These are called Murcha, that is unconsciousness, Brahma, that is confusion, and pralapa, that means delirium. Ati nidra means drowsiness or excessive, which is stemming out from pathological process of mind. And avasada, that is dullness or lethargy, which also can be covered using, for clouding of consciousness. Now, the definitions of consciousness and unconsciousness. What is consciousness? According to Fish, it is a state of awareness of the self and the environment. It is to be conscious, to know about oneself and the world. It has been described by Scaffater. And there is another definition. By consciousness, it has been described as I simply means those subjective states of the sentience of awareness. All these definitions cover awareness and sentience that end when one goes to sleep or night or falls into coma or dies or otherwise become, one would say, this unconsciousness. When conscious is not there, it is called unconscious. There are few characteristics or attributes of consciousness. I'm not going to very much depth of this. There are three attributes that is called qualia or qual. It is more of a term used in philosophy, which is used for something which cannot be described by language or any known form, but it has to be experienced. And this is the core character of consciousness, which is experienced by itself. Like they've given the example of redness of the color red. Similarly, it is both applied to objective and subjective senses like soothing feeling of a song or lullaby. And the consciousness is intentional. It is going to illuminate our worlds, both outer and inner worlds, thereby generating some content into consciousness. There is always something in the consciousness that experience of world is enabled. This is called intentional, and it is not to be confused with the will or volition what we have. And the third attribute is conscious self. Like consciousness is vastly involuntary, that if you're not asleep or unconscious or diseased, that means you are conscious. But the degree or quantity of consciousness varies, which we'll deal in future slides. In a nutshell, conscious is the quality of awareness of experience and being deliberate to experience and aware of self. Who is experiencing all these things? That awareness of self is also included into the consciousness. The conscious experience is unfragmented and unified. It is like it runs a whole thing like a movie and not like some random photographs. Then if we know consciousness, we also have to know what is unconsciousness. According to Asper's, something that is not an inner existence and does not occur as experience is unconsciousness. Secondly, something that is not thought of an object and has gone unregarded. Thirdly, it is something which has not reached any knowledge of itself. This will be made a little more clear in future slides when we see conscious continuum. When the degrees of consciousness are put in a spectrum, so this is where the white portion is all of us are now alert, and there are various states of consciousness that are described where the experience and all the other mental functions gradually diminish, which in future slides we'll understand when we individually deal with what is clouding and drowsy. Clouding, drowsy, sopor are also called as torpor, coma and dead. And there is one star here. This is more than being alert, like intense states, vivid states like ecstasy, where will be increased alertness or increased experiencing, which we can't do it in normal states. It's called. The next is when we sleep. This is in a pathological manner. If there is something abnormal which is happening in the brain, which might be due to various It can be neurological damage, organic conditions like metabolic or endocrine or infectious, where it starts affecting the arousal mechanisms of our brain, which results in various degrees of diminished consciousness. And this is rather normal, where we every day we sleep, we get drowsy, deep sleep. So being awake is in one state, and going on reduced way of experiencing thing drowsy and light. And when we are into deep sleep, we have probably very minimal experience of the outer world. And what we can see, the third uh, explanation of what is unconscious will be, we are seeing many things in this slide. The most prominent is the big circles 1 2 1 3, and there are many other bubbles or circles. And many of you would have observed or may not have observed, there is small mesh like background. So this is what we don't usually recognize. There are many things in this whole world which is enabled by our consciousness to register, but many times we don't usually attend to those things. And our mind also keeps working in many such states. It is unconsciousness, consciousness, and we call it as pre-conscious. See, this is one thing. What we are able to see is here an iceberg floating in a sea. But what we usually don't see is the iceberg has a lot of mass which is submerged in the water. So usually our mental processes will be one thing. What we can see in the consciousness in the clear air is the only tip of the iceberg, but there will be a lot of functions happening inside which may not come into our conscious experience. Now, coming to dimensions of consciousness, it is explained in 3 dimensions. One is vigilance, and the absence or diminished vigilance is drowsiness, and lucidity versus clouding, and consciousness of self. Let us know what all these things are. Vigilance is to deliberately remain alert. What promotes vigilance is motivation, interest on some tasks, where it can be anxiety to avoid from the danger, extreme fear, and enjoyment. And sometimes stimulant drugs also enhance the vigilance. When vigilance comes down, it may result in drowsiness. There are variety of repetitive tasks, monotonous tasks, boredom, lack of stimuli, exhaustion. Hypnotics and antihistaminic drugs promote drowsiness. Here, drowsiness in progressive stage of drowsiness, the experience from the outer world is diminished. And what is lucidity? Lucidity is one more characteristic of consciousness, where the clarity of experience and thoughts. This is just for a symbolic expression of what is lucidity, how what makes things clear. When to understand clouding, when the conscious is clouded, generally it may not be drowsiness or it might not be a sleep state, but generally there will be some impairments in attention, slightly lowered conscious states. It can be agitation or uh, retardation of psychomotor activity, but it just prevents things to be perceived in clarity. It is also associated with some memory disturbances, orientation, thought associations, judgment, and ability to communicate or do purposeful action. All these can be due to clouding. It may not be readily abnormal. Many of the acute psychotic states can have this kind of picture. Many epilepsy, especially complex partial states, can have this kind of clouding of consciousness. Now, pathology of consciousness. Coming into pathology of consciousness, it can be understood in 3 headings. One is quantitative lowering and qualitative changes in consciousness, and other terms which will enlist in future slides. We all know consciousness is closely associated with arousal mechanisms of the brain, which is situated in reticular activating system in the pons. And sleep results in inhibition of the same. What we have previously described, when a person is motivated, consciousness, tasks in the conscious requires motivation as well as strategy and plans. But parallel tasks are difficult when we are consciously focusing on something. Pre-conscious is one thing where simultaneous tasks are done, which are more of automatic things like driving a car and yet thinking many things. Even sometimes we will be able to talk in the phone also, which is of course dangerous. And unconscious, many things which may not come into the conscious experience, but still will be actively working out. And the conscious state, while we are awake, we'll be able to do most of the tasks which are described in consciousness. And progressively, when we become asleep, the conscious experience also will be diminished. And coming back to that spectrum, all these are mental faculties: thinking, attention, perception, memory, awareness of environment will be to its fullest when we are alert. And it quantitatively reduces as the consciousness state decreases. Clouding, we have already known. Drowsy is one state where a person appears to be awake but goes back to sleep with some stimulus. Depending upon the amount of drowsiness, we can still wake the patient, but he'll be generally in a reduced state to experience these things. His attention will be low and perception will not be as clear as alertness. Sopor is one pathological state where patient conscious state is characterized by excessive sleep, and it can happen due to various metabolic or toxic insults to CNS. There are a variety of space occupying lesions, even post-epileptic states. Everything can cause this state, but it is still, we can wake the patient with some amount of stimuli. Coma is one state where it requires unusually high amount of stimulus, or sometimes no stimulus can make the patient go back to these more alert states of consciousness, and the insult to the brain and activating systems or arousal systems of the brain will be severely hit in this state, and finally culminating in death, where not, consciousness is probably we can expect it to the zero. And we all know about this scale, Glasgow Coma scale, which tells which grades the various states, quantitative lowering of consciousness, which I don't elaborate here. This is important in order to assess the organicity of the insulting condition, most commonly used in head injury. Now coming to qualitative lowering of consciousness, there are few states which are described here which cannot be put in the quantitative spectrum. These are delirium and fluctuations in consciousness and confusion. These all terms are used in various meanings. There are a lot of confusions in each of the, especially this last term, confusion, which is used in variety of different parlances. Coming to delirium, there are various definitions. We'll just ponder through important definitions. Lipovsky has described delirium as a transient organic mental syndrome of acute onset, characterized by global impairment of cognitive functions and a reduced level of consciousness, attentional abnormalities, increased or decreased psychomotor activity, and a disordered sleep-wake cycle. DSM-4 has described it as a disturbance of consciousness that is accompanied by a change in cognition that cannot be better accounted for by pre-existing or evolving dementia. And ICD-10, which has been most commonly used, this definition is an etiologically non-specific syndrome characterized by concurrent disturbances of consciousness and attention, also perception, thinking, memory, psychomotor behavior, emotion, and the sleep-wake cycle. Most of the mental faculties are disturbed here basically because of disturbance of consciousness. And there is a new perspective here. Fleminger in 2002 compared the delirium to be similar to a dream-like state, but has a more vivid experience, and it is more aptly called as a disturbance of sleep-wake cycle, which results in disturbance of consciousness. And delirium, as we all know, as we have usually see it in everyday settings, there is an underlying cause most often, if not dementia, and unless it is found out, uh, the meaning of delirium or treatment of delirium is never complete. Just to understand it in the context of disturbance of consciousness, these definitions would help us. But this is not all the description of delirium. And other terms related to impairment of consciousness are twilight states, automatism, oniroid or dreamlike states, stupor, and some disorders of sleep, which is better not dealt in this section. We'll go with twilight state. Twilight state is defined as a well-defined interruption of the continuity of consciousness. And Leishman has defined by characterizing it as abrupt onset and end, variable duration from few hours to several weeks, and the most important thing is occurrence of unexpected violent acts or emotional outbursts during otherwise normal quiet behavior. And why this twilight state becomes important is it is commonly taken as a defense, uh, and it has forensic implications. Before we deal with a twilight state, it is important for us to demonstrate the occurrence of similar episodes with inexplicable behavior before that key happening. If something of medical legal importance has happened, it is useful to demonstrate this in the history. Other objective evidence of physical and mental illness also give rise to the causation or the probably background illnesses. There are two well-defined states which can be included in twilight states. One is Ganser state and pathological intoxication, which is also called as mania or POTU. These are kind of twilight states. Let us see a little more on mania POTU, pathological intoxication. Keller has defined it as extraordinarily severe response to alcohol, especially in small amounts, marked by apparently senseless violent behavior, followed by exhaustion, sleep, amnesia for that episode. And Coyle has described 4 components of pathological intoxication. Condition follows consumption of variable quantity of alcohol, senseless and violent behavior, then ensues, and there is then a prolonged sleep, total or partial amnesia for the disturbed behavior occurs. And this is often taken as a defense because it results in partial or sometimes total amnesia. And coming to automatisms, we would have commonly seen this in neuropsychiatric clinics or epilepsy clinics, which commonly accompanies complex partial attack or as an aura. Automatism implies action taking place in the absence of consciousness. This is important. It is classified under the disturbance of consciousness. It is defined by Fenwick as follows. An automatism is an involuntary piece of behavior over which individual has no control. The behavior itself is usually inappropriate to circumstances that may be out of character for the individual, can be a complex, coordinated, apparently purposeful or directed, though lacking in judgment. Afterwards, individual may have no recollection or only partial or confused memory of his action. Most commonly happens in the setting of epilepsy. Oneroid or dreamlike states is defined as when a patient is disoriented, confused, and may experience elaborate hallucinations, usually visual modality. There is impairment of consciousness and marked emotional change. This is important here, which may be terror or enjoyment of hallucinatory experiences. There may also be auditory or tactile hallucinations. And we would have seen patients acting out in the states of delirium as though they are in the work. The patient may also appear to be living in a dream world. This is called as occupational delirium. It can be uh, taken a reference in this kind of states. And stupor is one state many of us have difficulty in defining, and it still has debates. Uh, Stupor names symptom complex. It is a state where the central feature is the reduction or absence of relational function. That is, importantly, action and speech. The patient is unable to respond. Patient may be awake, and it is distinct from coma because it does not lie on a continuum from wakeful to coma. What we see that saw that conscious continuum, stupor lies out of it because patient may be awake. This term should be reserved for the syndrome in which mutism and akinesis. Mutism is absence or very minimal speech. Akinesis is absence of movements. That is the inability to initiate speech or action in a patient who appears awake or sometimes even alert. It usually occurs with some degree of clouding of consciousness, but need not be solely diminished level. Patient may look ahead, the eyes may wander. We would have seen this in catatonic states. There is again a debate in psychological versus neurological definitions, where psychiatric definitions often add the term in clear consciousness, whereas neurological definitions vary because a lot of organic conditions results in uh, various states of diminished consciousness. There are two well-known syndromes, akinetic mutism and locked-in syndrome. Uh, we can explain this in later stage or probably in the discussion hour. These are the examples of stupor state. Now it has already 25 minutes, so I'll go ahead with experience of self. This is what with consciousness and disorders. Now experience of self is one more other fundamental issues. We'll understand the concept of self initially. It is not so easy to understand these fundamental questions of self because self is a very complex construct, and what we may feel. There are many overlapping terms used in many contexts, but when we read it in various contexts, we'll understand in a different manner. So we'll stick ego to the subjective reference, and maybe the core of our concept of self is formed by ego or self subjective awareness of ourself, which I'll be explaining what are the components. The next is our body can act as both subject as well as object for us because we can feel our body, we can experience it with all the five senses or six senses probably. So this is the bodily awareness and the image of the body, which can be called as objective self. And also we have our own social image, the way we behave, the non-verbal communications, our attire, all these also are the part of ourselves, and even our work, our religion, culture, ethnicity, all those are incorporated into the social self. So all these encompasses into the concept of self. But we'll focus more on ego or subjective aspects. Coming to experience of self, there are 5 definitions which are described by Schaffer, and it has been divided into these 5 dimensions. Like one is vitality, ego vitality, the feeling of awareness of being or existing, activity, the feeling of awareness of one's activity, unity, like it is awareness, ego consistency and coherence, which I'll explain in future slides, and ego identity. This is awareness of who I am, and the distinction, awareness of boundaries of self, that is ego demarcation. What is experience of self? These are the feelings. I'll be just describing the taglines where we can try to understand what is experience of self or vitality. Like this is I am alive, world is real and alive. So when we feel that we are alive and we exist, this is called vitality. And we are sometimes in disordered experience of self or ego vitality, these questions may arrive. Am I alive? Do I exist? Does my body exist? Is the world real? Does my organs exist? These are all the questions. Otherwise we will not get such kind of questions. In disordered sense of ego vitality, the patient may feel as though he's dead, or feeling as though dead. His body does not exist. There's nothing in my body or mind. I don't have feelings at all. World doesn't exist. Everything is unreal or dead, just like I am. This can be seen in extremely depressed, uh, or it's called as nihilistic delusions or nihilistic ideas. This is a disordered experience of ego vitality. The next domain is ego activity. We can compare this with these lines. The normal self experiences and knows I did this as an action of myself. I made this. I decided this. This is attributed to will or volition, and it is me. It is being active, or I felt this, or this is my opinion. All of the uh, activity of mind and body are being acknowledged and known by self, while the abnormal self may feel like this, like I didn't do this, someone is making me doing this, someone is controlling me, I have no control on myself, this is something which I don't want, I don't know whether I want or not. Like these aren't experienced by me but are made. Each of these has a meaning which is relevant in future sections. These aren't my thoughts and these aren't my feelings. This is the ego activity. The next is the experience of ego unity and continuity. See, since when we born until we die, we remain as the same person, right? But when it is disturbed, it may not be so. Like in the normal self, we feel I am the only one of my kind, I am myself, anybody or anything else cannot become me. I know who I am. I am myself from the moment I'm formed, and I know what is my body and mind feel like. I remain myself all the time. But the abnormal uh, uh, ego unity and continuity disturbances may look like patient may tell I am no longer only me. There is someone in me who is another me or somebody else. There is someone else outside who is me. Like there is one more person who is also me. And there are many me's. I have many me's who are different. Till that day, I was myself, and today I'm no more. but a different person. See, there is a discontinuity in the way we feel as the same. I wouldn't be me tomorrow, or somebody else has invaded me. I have become her or him. A spirit took over me. I no longer remain myself. These are the disturbances in unity, and which are all interlinked. And there is these kind of experiences which have been elaborately described. Broger and Rigard in 1997 has described various disturbances of ego unity and continuity, where a person might feel uh, different from himself. There are strange or kind of unusual experiences. They have described it as called autoscopy. Okay, autoscopy or heutoscopy, which is described by Fish in 1967 as it is a strange experience in which a person sees himself and knows that it is he. But what differentiates it from other psychopathologies, it is not just a visual hallucination, because kinesthetic and somatic sensation must also be present to give the subject that impression that hallucination is he. So a person sees himself in a different space. There are 6 types of autoscopy with or heutoscopy described as a disorder of ego, unity, or singleness. Feeling of presence, negative autoscopy, autoscopic hallucination, OBEs or out of body experiences, and heutoscopy proper. What is being described by Fish is heutoscopy proper. And these are the images why I've displayed is these are very difficult to describe in words. So there are many reports which have been compiled, and we can see it in the textbook Sims. I'll just briefly explain with only one line. The feeling of presence, like there is no other sensation in the modality, is more of private or subjective feeling of presence of usually same person, which results in ego discontinuity, or it might be someone else who is always present in the vicinity. And negative autoscopy is usually when we see in the mirror, we see our reflection, but many times these persons see, they may not see the reflection, or they might feel that they are not there. And autoscopic hallucination, in the definition of autoscopy, they have told kinesthetic and somatic sensation must also be there. But as the definition of hallucination, we all know, autoscopic hallucination just reminds to the specific modality where a person can see partial or complete self, either in the visual or any other hallucination, commonly visual modality. And out of body experiences, what we can see in this picture is it usually results in a person himself seeing his body, usually from an elevated visuospatial space, and this including the sensations. Uh, and heutoscopy proper, as we have described these things. Usually the reports have been, there are variety of near-death experiences and all. So these kind of phenomena are described more or less like near-death experiences, but also commonly seen in epilepsy, especially complex partial seizures, sometimes as aura of the CPS, and also in many organic states of the brain. And one more disorder in the same modality, that is multiple personality disorder or dissociative personality disorder, which has been extensively described in Western literature, especially North American, where a person assumes a different identity, and both the identities are concurrently existing probably in the same person, and each identities have different control or being controlled in the same person. There are a variety of reports which, if I keep explaining, it might result in another 1 hour. So we'll just stick with the types of multiple personality disorder. And it is a very debatable issue. because the subjective reports are very difficult to assess, and there are three types of MPD that are described. One is simultaneous partial personalities, which exist concurrently, or successive well-differentiated partial personalities, which might be there at one time, and after some time, a new identity will take over. And clustered multiple partial personalities, where there might be multiple existing personalities which has various control, or sometimes one identity or one personality may not have a memory of the other personality, while one might be having complete experience or knowledge on the others. So the next domain is ego identity and continuity. Why I have added continuity? Thus continuity is relevant here also, but we'll focus on ego identity. There are few states like trance and possession, which is quite common, and most of us have seen in this part of world, where the identity of the person is disturbed. Also, they have altered consciousness, transient, associated with loss of identity. Trance is just one state where temporarily identity is affected. There may or may not be new identity or uh, things like that. But possession states, which are more common, where usually with replacement of identity will happen either by some spirit or deity will take over. These are the usual pictures what we see in our routine practice. And there is one more phenomena called lycanthropy, where patient believes that he has been transformed into an animal. More commonly, wolf, tiger, sometimes in this part of world, snake, etc. And one who has seen Twilight movie would have definitely aware of werewolves and all. So all these vampires and werewolves, they belong to kind of this phenomena, lycanthropy. And finally, to deal with ego boundaries, which we'll all know, because in patients with schizophrenia, we commonly have encountered all the first rank symptoms, and like thought alienation phenomena, passivity, delusions of control. So just to understand, we need to just understand what are these ego boundaries. All that has been described before is just a other way of explaining, right? Subjective self, what this is the core of our ego or self experience, where I myself, I think, feel, believe, my opinion, plans, or whatever. And the next, this is still the self there, but there exists a definite demarcation where I can know what is my feeling, what is my subjective sensation, and how my body feels, my hands, organs, I see, hear, taste, smell, everything that is coming from the outside world. This is objectivity of the self. But there is something which lies outside. It has been inhabited by variety of non-living and living things. They, the world, you, yours, things, everything which is not ours. There exists a clear demarcation. Otherwise, in normal, healthy persons. But during disturbed of ego, I mean, when there is loosened or dissolved ego boundaries, there might be a lot of disturbance that can happen. This is just to understand objective and subjective space, which we can skip now. And these are the usual disturbances what we see: thought broadcast and other thought alienation, made experience, made affect, made actions, and passivity phenomena. These where I end and not I will start. Sometimes there may not be the clear demarcation. So in states like schizophrenia, where this ego boundaries are dissolved, an external agency might feel like it would have patients would have felt that some external forces are organism or something like spirit that have taken over control of self, that is influencing all the movements and uh, mental faculty or mental activities of a person. So this is thought broadcast, where affected person may think the whole world is coming to know about my thoughts and whole world is thinking in unison. And passivity is like losing control on our own body parts or thoughts, where some external agency have taken over. Same with delusion of control. But what is slightly different is this ecstasy, which may not happen or may happen in schizophrenia, where there are some heightened experiences, heightened consciousness, where a person might feel that he may not exist anymore. He might have thought he is one with God, one with saints, and some transcendental feeling might take place where ego boundaries are known to dissolve. It also happens in under the influence of many drugs like LSD or even stimulants, cannabis, and this is with disturbed ego boundaries. This is one relevant picture what I found useful, which is there in SIMS, Symptoms of Mind textbook, where a patient has painted his disturbed ego boundaries, where the person will be one with the flooring and also with the surroundings, where there is no clear-cut demarcation, and person's mind is probably being controlled by many other forces. Uh, do we have time to go with this depersonalization? Uh,
Maybe quickly.
Quickly, I have only very few slides. So why I have taken up this depersonalization is one, subjective experiences where uh, self is also involved, and to go on with I'll just hurry with the definitions. What exactly is depersonalization? Uh, there are some D definitions like depersonalization, derealization, somatization, affectual. We'll just rapidly go through this. Depersonalization is a subjective state of unreality in which there is a feeling of estrangement, either from a sense of self or from external environment, where we feel stranger to ourselves. Derealization is a term denoting a similar feeling, but with regard to awareness of external world, where the external world seems very unreal. Uh, and desomatization refers to localization of feeling of this unreality to a selected part of body, where I don't feel my hand to be mine anymore, something unreal. And de-affectualization has been used to describe consistent loss of capacity to feel emotion. So that person seems unable to cry, love, hate. There are variety of related terms where a person cannot feel numbed emotions. So this need not be confused with all these things, but more or less, this is a temporary state which happens in depersonalization. Affect is invariably involved. Depersonalization is a term used to designate a peculiar change in awareness of self. Why I've highlighted is it occurs as if person retains insight and he just feels as if it is unreal. And why this depersonalization, understanding the concept is important is because it is most frequent symptom in psychiatry after depression or anxiety. Very commonly reported many times in various states, including any disorders, any mental illnesses, and also epilepsy, substance use, withdrawals. One comprehensive definition given by Ackner includes depersonalization is always subjective and disorder of experience. Experience is that of internal or external change characterized by feeling of strangeness or unreality. And these are the three important things. Experience is termed as unpleasant, is felt unpleasant, and any mental functions may be subject to this change. But out of those things, affect is invariably involved, and insight is preserved. Excluded from depersonalization or experience of unreality of self when there is a delusional elaboration, ego boundary disorders of schizophrenia, and loss of attenuation of personal identity, which we dealt in previous slides. These are excluded from depersonalization, but very difficult to tease out when the patient is describing. And these are components. I'll just rapidly go through this. Emotional numbing, changes in body experience, visual experience, auditory experience, tactile, all these are sensory experiences. Loss of feelings of agency, distortion in experiencing of time. This is one added feature here. And changes in subjective experience of memory and feelings of feelings of thought emptiness, subjective feelings of inability to evoke images or imagining, heightened self-observation, which results in all these things. And I'll skip this slide. There is one scale called Cambridge Depersonalization Scale, which essentially describes all these in 5 factors. And these are phenomenologically distinct but often reported along with depersonalization, which are disturbance of body image or schema, which is not being dealt in this session, disorder of subjective time sense, hypochondriacal preoccupation, and deja vu phenomena. These are memory disturbances or dissociative experiences, and metamorphosia, the distortion of visually perceived objects, and schizophrenic passivity experiences. All these can be frequently reported but can be excluded in strict definition of depersonalization. Okay, these are the references which I've used, mainly Sims Psychopathology and also Fish Psychopathology book. There's one article. Okay, thank you. And now we'll open a session for discussion. Thank you, everyone.
Thank you, Gopal. There was one question from, I think, Dr. Akansha Bharadwaj. Can you please tell the difference between stupor and sopor?
Okay. Sopor, first of all, what I told is it lies in the conscious continuum. Sopor is more or less abnormal drowsy state where a person cannot be waken up very easily. Stupor is one state where a person can be even awake and look alert, but the patient is not able to respond to whatever or we may not be able to document the responses of patient. More commonly, more importantly, speech and movements are affected in stupor. This is only phenomenological, psychopathological differences. In neurobiological, stupor is more commonly the areas affected are frontal lobe and basal ganglia, whereas sopor it is usually generalized or more commonly arousal mechanisms are affected. It is more of diffuse in sopor. Sopor is not very clearly delineated and well-used term in routine clinical terminology, but stupor is usually seen many times. If that answered the doubt, it's fine.
How to differentiate? I think an older term for that is also torpor. Next
Torpor,
question,
yeah.
how to differentiate between depersonalization and derealization?
Okay, depersonalization is more of where a person feels he is unreal, he is estranged from the world, where derealization is a similar phenomena where a person remains intact, his sense of experience of self remains intact, but the world seems very unreal. This is the main difference between derealization and depersonalization, but very commonly both of them are experienced. Probably there is one number like 19% and 14%. Depersonalization is slightly more common in presentation. This is essentially, it is about the self and the world.
Okay. Please put your questions in the question answer box, not in the chat box. Okay, Dr. Mahi wants to know, if psychosis is a disturbance of awareness, what can we do to make the person aware apart from using pharmacotherapy? I don't know whether this is really a part of this particular presentation, but if you want to quickly address it, please do.
Yeah, generally in psychosis, there are various theories of psychosis, causation of psychosis. But here, as you have asked, the sensation of self, it is one part where these are fundamentally disturbed in psychosis. And there are variety of neurochemical theories which have been described in causation of psychosis. Uh, if the person is able to perceive the self and conscious is not disturbed, uh, we can engage the person in maybe uh, therapies or kind of insight facilitation, whatever it is. But these are the fundamental disturbances, self and consciousness, where person may not be able to actually engage in a meaningful therapy or conversation. He's kind of confused or disturbed in that manner. Thereby, the medicines may work better in this kind of states initially. This is what my opinion is. I think sir might be able to explain.
No, I think we should move ahead. Dr.
Yeah,
Saju John wants to know the difference between akinetic multimedia. I think he means akinetic mutism and
yeah.
locked-in syndrome.
Okay. Locked-in syndrome is one very rare state, which happens because of lesions in rostral pons on the ventral brainstem in this area, where the descending motor pathways will be affected and patient will be paralyzed, where there is only eye movements, that is horizontal eye movements will be left intact, but preserved consciousness, where it renders patient totally akinetic, but patient will be able to uh, kind of experience everything what is going around him, and but he'll not be able to respond. Maybe a patient might be able to respond with only eye movements, is what I know. In uh, akinetic mutism is more or less what we see as catatonia. Akinetic mutism, where there will be a disturbed conscious state also. The uh, areas which are affected, as I earlier told, this is more diffuse here in akinetic mutism, where basal ganglia is more thought to be involved and connection to frontal lobes. Uh, this is what we usually deal as catatonia. Maybe, probably this is what I could explain. These are the differences. In akinetic mutism, patient may remain awake or slightly clouded or might be drowsy. There will be yeah, this is what the difference I could
Yeah,
give.
yeah. Dr. Panchami Pinku wants to know, how do we differentiate nihilistic delusion with respect to denial of existence of body and desomatization?
Okay, here in, as we tell it, in depersonalization and derealization, the desomatization usually is more or less localized, which is phenomenologically quite similar, but desomatization, generalized desomatization is not very common. More or the reports are more commonly localized to either one part of the body or one part of the uh, system, where but nihilistic delusion again, here they might feel the existence. In desomatization, the insight is preserved. Like the person says as if my body part is not there, and more or less these states are temporary. But in disorders of ego vitality, where usually these are found in severe depression, Cotard syndrome or something like that in elderly, where they start feeling their organs does not exist. And this can be generalized, where they may not be just limited to one or two organs in the body, but the whole sense of existence itself. In derealization or desomatization, the whole sense of self will not be usually disturbed. This is what is primary difference what I could explain.
Dr. Abhineet Sanyal wants to know, can you please elaborate metamorphopsia a little more in view of the disturbance of ego boundaries or clustered personalities?
See, metamorphosia is one disorder of perception where what we usually perceive, the material dimensions of the object we perceive will be altered. The other thing, what is compared, sir?
No,
What is that?
in view of ego boundary disturbance
Okay.
or clustered personalities.
Okay, okay. So in metamorphosia, usually ego boundaries are not generally disturbed because it is more of an altered perception where the person sees objects as different in a different size or shape or even the characteristics attributed to it. But in disordered ego boundaries, a patient or a person might feel that object is him or object is controlling him or he himself has become a part of object. So this is the vital difference between these two. This is widely different phenomena. And the clustered personality, honestly telling, these even I need to go a little detailed reading in MPD. What I understand with clustered personalities with partial awareness is there might be multiple personalities that might be existing in either same time or different time. One personality may be primary and will be controlling the other personalities or will be aware of existence of other personalities, but there will be many subsidiary personalities which might be entirely different in identity, which may or may not have uh, full awareness of primary personality or the person who they belong to. This is more of discontinuity in the sense of self, where uh, at the same time all the personalities can present, or at some point of time only one will be there. It depends. There are various notes on multiple personality, which are again it's difficult to uh, stratify data and derive a meaningful scientific evidence
Yeah,
out of it.
there's a fair amount of controversy also involved.
Controversy, yeah, yeah.
There's an
Some even say,
anonymous attendee who says, please tell about subjective and objective space in regard to hallucinations. I think we'll take just
yeah,
2-3 more and then stop.
sure, yeah, sure, sir. Yeah, this is the fundamental thing every psychiatry resident has to know. Subjective space and objective space are two different, clearly demarcated spaces uh, where objective space usually follows everything. It exists in reality. It follows the physical rules where objects will be there and they can be described and experienced using our all the senses. Where in subjective experiences, these are the like I am feeling, I think, this is my opinion. This does not have any length, breadth, or anything. So this is mainly what we usually feel, and we usually call it as internal world. Even the bowel movements or heartbeat, whatever it is, it still comes from the outside. We feel it through kinesthetic sense or auditory or even visual many times, but not the subjective thing. So in hallucination, the fundamental definition is the experience is as though coming from the objective space, and it is clearly heard in clear consciousness. But subjective experience, this is compared to imagery where we don't feel that objectivity in the imaginations. When we feel some song or croon some song, it will just be inside our subjective space. We enjoy this, but hallucination is not like that. The other thing is, in objective space, we don't have any control over that. Anything outside our body, where a hallucinatory voice we cannot control. If we tell stop, hallucinatory voice may not be stopped. So this is the vital differences.
Okay. Can you, Dr. Saju John, can you explain the difference between a psychiatric and a neurological stupor?
Yeah, this is one more controversial area. Just like wherever psychiatrists and neurologists always have debates, here psychiatric definitions more often demand a stupor to be diagnosed or uh, detected only when there is clear consciousness. This is the prerequisite for psychiatric definition. But in neurology, we see usually organic things where there is a lesion or a demonstrable pathology, which also might get generalized, usually resulting in slightly clouded or deranged quantity of consciousness. So neurologist usually doesn't uh, keep on insisting that for to diagnose stupor there should be clear consciousness. So this is the main differences
Yeah.
between what psychiatrist and neurologist.
For us, catatonia, functional catatonia, there is intact consciousness, whereas in an encephalopathy producing stupor, there will be an altered consciousness.
Yes,
Dr. Nimi Gupta, please could you tell the difference between twilight state and delirium?
Okay. In twilight state, these are similar actually, where there is disturbance of in quality. There is nothing like diminished consciousness or heightened consciousness, anything. Delirium is more or less a state resulting from some underlying pathology, whereas twilight state is also that. Delirium is more established. Here patient has some issues with sleep-wake cycle and alertness, attention, concentration, whereas twilight state is quite transient, where there will be usually some emotional and behavioral problems. In delirium, there will be more of diminished, like altered or even reversal of sleep-wake cycle, and a lot of hallucinations and disorientation. All the mental faculties are disturbed and might be either agitated or even sometimes depressed. In twilight state is not like the disorientation is not so characteristic. Where here, more or less, there will be subdued consciousness, sometimes even resulting in amnesia. It's not very easy to delineate from a delirium and twilight state. Many times when they present,
You could actually, you could say that they are similar in characteristics. Yeah. Doctor, the last question, Dr. Mahi, is there a way we may become aware of our unconscious mind, since so many pathologies arise from the unconscious? What way do you suggest in trying to become aware of our unconscious workings? Thank you, sir, for the informative lecture. I think this question is a little out of syllabus, but anyhow, if you want to answer it, please do.
I actually didn't understand it completely, sir.
He's asking whether how to become aware of our unconscious mind.
I fear there is no particular one single way to understand unconsciousness, because it is as deep, and there are psychoanalytic techniques that are described from a long time, where we can just peep into our unconscious mind by analysis and interpretation. That's all. There is no direct method to see what is happening in unconsciousness. That's why I've compared it to the black hole in one of my slides. This is what I feel.
Yeah, we've come to the end of the questions. We can wind up now, Dr. Narayan.
Yes, sir.
Yeah. So thank you, Dr. Gopal, for a nice lecture. I think it is a huge topic to cover. What I would suggest for the postgraduates is that while you talk about disorders of consciousness, you should really be aware of what is consciousness. And until you have a clear grasp of that, this is like saying this is not it, so it is this. So it is important to know that, and I'm glad that you brought up the issue of qualia. It is a fundamental issue in understanding consciousness. And it is necessary to know that consciousness is core consciousness and extended consciousness. So it's an important area, very large area that you've covered, and you had pretty nice visuals also. Thank you.
Thank you.
And thank you to the IPSKC for giving me this opportunity to chair.
Yes.
Thank you, sir. Thank you so much.
Thank you, PSVN Sharma sir, for chairing this session. And I would like to thank today's speaker, Dr. Gopal Das, for a wonderful interactive session on the topic. And I would like to thank our co-moderator, Dr. Harish Kulkarni, and entire IPSKC team, president and secretary. And finally, I would like to thank Icon Life Sciences for wonderful cooperation. Thank you. Thank you very much.
Thank you. Thank you, sir.
Wind up, sir.
Good night, everyone.
Good night. Good night. Thank you. Thank you.